unilateral, biportal, monoportal, biportal, or destined to. The technique may be vary, but we should adopt the technique which we are confident with. So I thank you, Dr. Ranjit Deshmukh sir, to select this topic and selected the very good speakers and panelists. So the discussion will be the cherry on the cake. So I hand over to Dr. Ranjit Deshmukh sir to start the webinar.
So, good evening, everybody. We will directly start with the webinar. I do not need to stress the importance of getting into minimally invasive and endoscopic spine surgery for neurosurgeons. I always feel that as a neurosurgical community, as teachers, colleagues, we have lagged behind orthopedic spine surgeons, and slowly we are sort of losing, not call market share, but we are lagging in that. uh, Let me introduce our star speaker, Dr. Atmaranjan Das. He is pioneer
Thank
neurosurgeon
you.
in endoscopic spine surgery. He has an international fellowship and he has trained tons of Indian and foreign uh, neurosurgeons and spine surgeons in the same. He's a distinguished neurosurgeon. He's a chief consultant in Care Hospital, Bhubaneswar, and I think he will give a fantastic presentation. He many times, I mean, I'm still very slow, but many times people feel that endoscopic spine surgery is slow, it takes times. So you should go and watch Das operating, or you should see his videos. uh, he finishes this within 10-15 minutes. So it's not about speed, but I really admire, and let us start from him. Welcome, Dr. Das, and
Thank you
thanks
so much,
for
sir.
making yourself available and taking out time. Half an hour he's supposed to talk. Dr. Ishan Nerkar won't be there with some problem. So we'll enjoy Dr. Das talk. Thank you, Dr. Das, for making it out for MCNS.
Thank you so much, sir, for the opportunity. Special thanks to Patkar sir, Majumdar sir for this speaking. We have seen you during my residency as inspiration. So we have grown with our inspiration. So let me put your inspiration into picture. So now I'm going to start the. Uh, just, just, can you see my video?
No, till now you have not shared your screen.
So I'm
Screen is
sharing
not
it.
set. We can see you.
Okay.
It is
So now, is it we are able to see now?
yeah, yeah, yeah.
So
Now we can see it.
if it gets stuck anywhere, please let me know so that.
Sure.
So as we know that the problems of spine issues are humongous amongst population. And a lot of patients, especially elderly, now suffer from midline canal stenosis, which is a very debilitating disease. Even the doctors and the physicians, they don't know what it is. What is canal stenosis? The patient walks normally, patient sits normally, look normal. Nothing happens. The game starts when he starts walk for a long distance. Laparoscopic surgery. So that was something which was very troublesome for the patients. So what we did is we try to understand this canal stenosis, and I could understand there are huge number of patients who are not getting the cure. They are visiting multiple doctors but not getting a solution or surgery because of fear of open surgery. Now we understand if an elderly patient is having a 1 liter blood loss, he are going to put long screws on the back, a big butchering surgery, nobody is going to turn up. If you think about your mother, grandmother, if you discuss about them, ki suppose I have my mother have severe canal stones, I will never go for surgery in this era of open surgical technique. That's a fact. We have to understand the psychological stress on a patient and the caregiver when you talk about a big major surgery on a back like cardiac surgery to a 80-year-old female or male. This is not possible. They don't buy it. So, can we offer our population an easy solution? Is it possible to manage multi-level lumbar canal stenosis, disc issues, everything with something which is easy for the patient? Patient comes here and you describe a painless procedure for them. "Ki, this is not going to be much painful for you. It is like a easy minor looking surgery, though it's a GA surgery, but it's a minor looking surgery. Everything can be taken up and you don't lose any blood." Those two words, painless and bloodless surgery, actually make them understand, go their psychological stress of the surgery. If you understand every other person is having canal stenosis or back issues, can we give a society something which is without any screws? Those screws are needed in some of the cases, but major of the cases does not need screw. Only a wonderful decompression without destabilizing is the key. So now any patient comes to my hospital, we tell them we are going to do a laparoscopy on the back. They understand it straight away. Okay, laparoscopy, the same abdominal surgery which you do. Yes, that is the same surgery. By two ports, we can do the surgery. If you ask me in a single word, every time we talk about back problem, everybody says it is a disc is the issue, we'll remove the disc. Actually, what time I could understand, disc was never a problem until and unless it's a broken fragment somewhere migrating and causing irritation. If it is intact, a bulge is minor, you don't need to remove the disc. In elderly population, the disc is gone, calcified, and it is has gone to a level of desiccation, which is not causing any problem. The problem is the phlegm, which is compressing all around. The problem is the foramen, which is because of the subsidence. Is causing the problem. So please do not screw my back. This elderly lady telling us, "Can you cure my back issues or walking issues? Because I cannot go to the washroom now. Whenever I'm walking, I'm bending forward. The walking is very difficult. Night cramps I'm getting, feeling of numbness. I was doing morning walk in the morning with my apartment friends. Now I'm not able to do it. What to do you offer something?" So the offer is like this. I offer because we have to offer a cure for the patient. Could not be adamant, "No, no, this has to be done. You have to go to the butchering just to have a cure." No, we have to find an easy solution. Suppose you have a tooth issues. Somebody tells you we can manage your tooth by a root canal thing without extraction. People will offer it. People will take it. People want an easy solution for their difficult problem. This is what the key of a doctor. So you see, this incision is a butchering, and this incision is a barely visible scan. No, where there is incision. So this is what the game of biportal endoscopic spine says. There is two kind of portal we play. One is a monoportal, other one is a biportal. But we have to understand monoportal is a good technique for discectomies. I don't deny single incision is okay. But why what all we need another incision on the back is about the technical issues with the monoportal. Monoportal started around, I believe, around 2010 to 2020, where they get a lot of popularity because it's an endoscopic and water saline medium technique. Because Destandu, the problem was all around there is bleeding. Destandu scope is also a bigger scope because the dilator easygo system is very heavy. Blood is seen at the corners, leading to all these meshy areas because the lateral disease is the key area. The foraminal area is the key area where work has to be done to cure the patient. So if you see, the monoportal camera is a very small camera. It's a 1.8 mm camera. But if you go to a biportal scope, it's a 4 mm camera. 4 mm camera is a bigger camera than a 1.5 1.5. So bigger camera, better pixeled image. Then we go to the size of the scope. If I offer patient to which scope you need in the back, definitely a smaller scope is good on the back. Why smaller scope? Small scope, big camera is the key for a biportal technique because it is versatile. It can go to the corners. You see, this is a drone picture. Can we see the drone picture? So you see, this drone is moving like a scope inside the canal. Now, when we talk about the phlegm removal, all this blind spot has to be taken care to produce result. So when it moves like a drone in the canal, seeing all those nooks and corners of the canal where it is compressing the roots. That is where we have to understand why endoscopy fails. Endoscopy fails because of this common issue. Why? Because this is a butterfly, which is like a phlegm. Phlegm has played a key role for preventing you to cure the patient. So you do a open surgery, but when you do the central work, you remove the butterflies all around. What monoportal does, monoportal can access these lower wings of the butterfly very well. They will also remove the upper wings of the butterfly like this, but the these areas which are on the top of the wings is left behind, which we call as a blind spot. It took me a lot of surgeries to understand blind spot, and this is a straightforward thinking why my patients were initially not improving, but they improved later on. Because if you understand the canal, these are four quadrant: quadrant 1, quadrant 2, quadrant 3, quadrant 4. This quadrant has the upper quadrant had the exiting route, and lower quadrants had the traversing route. So whatever we do, whenever we do endoscopic surgery, we take care of the traversing route. Nobody talks about the exiting route. That is why the O-leaf surgery, whenever do you do a T-leaf and O-leaf, this takes care of the exiting route as well as the traversing line. That is why T-leaf is a very workhorse surgery. But T-leaf, the addition of the T-leaf, you have to put screws, cage, break. The old patients are very afraid of screws. It's a big surgery for them, big pain. Have you seen a MI surgery patient on the next day? Very, very painful. When you are putting the patient on the MI screw, and the next day they go, they cannot lift up from the bed. After 2 3 days, they can anyway do this. Why to put screws? The point is the decompression. When you see the decompression, it is here we decompress, but what actually remains is this butterfly, these wings of the butterfly remaining at the corner, compressing the exiting route. That is why the patient improved partially with endoscopic surgery. This is what the key to success of biportal endoscopy. This is what I call as a midline biportal. You see, this is the midline, and you see these scans, these scars. It's just like a drain wound, just small dimples on the back, and the whole multi-level is taken care so easily. You can go till 5 level. That is what I'm going to show. So what we have designed, when unilateral biportal is one on the one side of the body, the midline biportal trigger on the midline is the spinous process. Whenever you talk about the spinous process has a thickness like this. So this thickness has to be taken care. So one is a midline, one is on the side, which is called as left midline, one is on the right side, which is known as right midline. So left midline, right midline, and this midline, midline. So the advantage is, because we are all mostly people are right-handed surgeons, so we stand on the right side, left side of the patient, and we operate on the disc. Suppose on the left side, so we dock from the left midline. If we are docking from the right side, we dock from the right discectomy, we dock from right midline. There is no way of going opposite side, changing the logistic of the center. Another thing is the triangulation and all these problems with the unilateral biportal endoscopy was cumbersome. So what we did, we removed the triangulation. So what we have designed, you see this first surgery, you see, we imagine, I'm not like Dr. Deshmukh told, time is never a point, but if you do the right docking, right point, easy looking surgery can be done fast. Even if you are slow at your every step, but surgery will be faster, because you know where to end and where to stop. This is a full surgical video I want to show. This is a raw unedited video.
Transferring camera, and there is some leak here. Just okay. Scope. Okay. So see how fast we can go there and start the process.
So this is midline biportal.
And
you see from this video, my hands are very slow. This is a natural surgery which is faster naturally. You see, I'm just doing there, I'm going there, and moving on the flavor. Just landed on the this is the upper lamina. So what, like we do in microscopic surgery, we do upper lamina, very small. Then we go to the lower lamina area. You see, there is a timer on it. Only 30 seconds we have reached to the both the lamina, and the interlaminar window is near me. I didn't try to make the surgery faster. So there's the surgery is naturally getting faster day by day. Now. So you imagine if we can master this technique, we can do faster surgery. How many discectomies we can do in a day? That will save a lot of money for the hospital. That will save a lot of time for you. I doubt hydrocele surgery will take longer time than this discectomy. So 1 minute over, I am reached at the flame. So I have developed this mind drilling technique, because this is a saline medium surgery. Sometimes the bone will obscure your view. So we are drilling the lower lamina, upper lip of the lower lamina. Now, once I drill the upper lip of the lower lamina, we'll put our calcium and do a laminotomy, phlebotomy. So the small lamina is just breached, no other part is removed. Then we start doing. No step is fast. Just so what we have done, 100-step unilateral biportal surgery is now converted to a 5-step procedure.
So
less number of
my
steps,
hand movement, you can
less
see
work for
how
the patient.
easy this surgery
So that
looks
is what
like.
we are doing. So see, I have reached to the root. No fast step. You don't see anything where I'm doing faster. I'm just doing it smarter. That is what
So
is
there is
the
no compression, only the disc is there. For calcium, please, coagulation.
this
So
whole
the
video
root
is
is
in
in front
YouTube,
of
which
me,
a total
coagulation.
video was 8 minutes. I have just trimmed it
Calcium,
out
please.
to
Calcium,
the
please.
initial part.
So you can see how this surgery and how fast this surgery can be done.
So easy offering faster surgery,
Only the
definitely
blister
good
is
for
causing a lot of
anesthesia,
problems.
is good for
The patient, very rare
patient. Small duration
conditions where
surgery will have
blisters
less
cause a
of the
lot of problems.
inflammation. I'm not
I call
promoting
that
any
blister
fastness
disc.
in surgery, but it has to be done smartly. Very slow steps, but
So please,
naturally the
coagulation.
surgery maybe take
Some
less time.
small losing will
But
be there.
initially, I say my first
Please.
biportal surgery took me 8 hours. The same surgery, same discectomy. So naturally,
So
things evolve over time when you
you
understand.
see
So
how
disc is out.
easily we can remove the disc.
So it's a very
And
easy
the
process.
time is 4 minutes.
I'm just removing as we remove the normal
Okay.
thing. And you can see
Root
2
retractor,
minutes
please.
54 seconds. And
And
we
this
have
is a
reached
disc
to the.
disposer, please. Okay. Hold.
So we are trying to educate with biportal endoscopy because microscopy have a
4
parallel
minutes we
vision.
are
So seeing the
on the
corner
disc.
work is definitely difficult. Second thing is whenever there is a new procedure, and another thing, people say you have done fast surgery, what about the result? See the patient walking on the stair, he's a police officer. He's a police officer walking on the stairs on the next day of surgery.
Having
So this is what we have developed this under the cave work. So we have all listened about the over the top decompression. So what is under the cave? First, before that, we have to understand what is a blind spot. This is a lorry. This is a big lorry. And the lorry driver is sitting inside the car and looking at the rear view mirror. He sees nothing. There is no one. But once he comes down of the vehicle, he starts seeing so many structures. So this is what is the problem with microscopic surgery. You feel you have done everything, but there is a missed fragment on contralateral side. You cannot see the exiting road. You cannot do the corner work because it's a parallel vision. And naturally, there are a lot of bleeding which at the corner. So you keep on spraying with saline to make it visualize. But what about if you have a saline all with you? So you see this case. This is a 4 level compression. You see the diameters. This is 3.2, 4.5, 5.8, and you have done a decompression at the end of the surgery. You can see with the small incisions, the patient is gone home, and there is no additional issues with the patient. Everything looks normal and fine. So all these phlegm are there all around and we have removed. So we have to understand the elderly spine. The elderly spine is the gap between, this is a young spine. The gap between the vertebral bodies are very good. The height is augmented. There is a good height between the two vertebral bodies. But if you go to the elderly spine, you can see there are a lot of subsidence. There is, the gap is reduced between the vertebral bodies, and there is foraminal stenosis. If you can take care of the foramen without doing an indirect decompression, or if you can decompress the canal without causing much of the trouble, then this is what the patient is needed. So if you see about the canal, this is what is the blind spot. I have discussed this with a monoportal surgeon previously. I said, how much phlebum you remove ideally? What is the ideal removal? So most of them said ki you just go to the lateral border of the thecal sac, that's it. But the actual lateral recess starts from the lateral border of the thecal sac. That is a very logical thing. You see this is the exiting root area where there is severe compression. You see the exiting root area, there is severe compression. You can understand this is a MIS surgery which was done previously with this patient, and the patient said, I had a claudication distance of 30 meters. Now after surgery, it has improved to 100 meters. It is okay, I'm going better, but not that better which I expected. So I tried to analyze. He was operated by another surgeon by MIS technique. Then I understood this looks okay. This is a good decompression he has done actually, but there is a blind spot. You see, the decompression is very good here, very good here. Whenever people post on the scans, wonderful decompression, no doubt about it, but there is a compression here. So if you understand the water is flowing through a pipe, you hold it like this or hold it like this. Both things are going to stop the water flow. Release it. So this is what we call the under the cave work. This is
And
a
if you see
cave.
this can,
This is a
this is
cave formed
split
by the
again.
this is a cave formed by the canal, and we dug the canal and the phlegm all together, making a wide bore area so that the current will flow nicely inside the canal.
And if you see this
So
can,
this
this
is
is
another
split.
scan how we do the under the cave work. We don't do over the top decompression. We cave through, making the canal wider so that the integrity is preserved, but the current flow is taken nicely.
Let's discuss about the
This is
recurrent lumbar
another
canals. What is
recurrent.
the blind spots? See this video where MIS fusion has been done at L3/4 level.
So here I'll demonstrate what is blind spot. This surgery was done previously, but there was a blind spot here. So what we did is we started. I'm so sorry. Is it visible?
With the radio frequency probe,
Yeah,
we
now
can
it is visible.
So what we did is we tried to so we started working on it. So I could see a whitish looking structure, which is generally different, definitely the scar tissue which is present there. And then we started digging through it. So I wanted to see why the patient didn't get a good relief. So what this is what I call as under the cave work. Like cavers dig through the canal to make their passage safer. So this is how we started digging it. So we could see there is a virgin looking phlegm which is known as a blind spot. This was exactly sitting on the exiting route. The exiting route was never decompressed, only the traversing route was decompressed. So we went there and started working on the exiting route and ipsilateral side. And this phlegm was there, and this was the reason why the patient never improved. So at the end of the surgery, I have could decompress the exiting route as well as the traversing route. So this is the exiting route on ipsilateral side, and that was the exiting route on contralateral side. I'll show you the snake here. If the snake is sitting here, that's the exiting route. That is because we can dug through the cave by a smaller scope. This is known as the biportal surgery. You see the previous open surgery, how nasty looking this scar is, and you see the patient had a adjacent segment disease, and I have done a biportal surgery. There is barely any scan, any scar. This looks like a drain hole, and you see the facet integrity is really preserved because of the under the caving work. So another congenital stenosis we can see here, and I'll show you how this patient, this is what the butterfly thing. So some of the Koreans started questioning me, why are doing biportal, you will damage the interspinous ligament. So I showed them with this video how the interspinous ligament is preserved in midline biportal. So we go there, hinge underneath the interspinous ligament, doing this decompression. So interspinous is preserved. This is the same patient with the congenital stenosis. Another patient, multi-level. Every day of my work is patient coming to me, sir, I went to another surgeon, they said you have to do a decompression and fusion together. So I didn't want, I want your solution. So we offer them, yes, we can do this, the integrity, the alignment, badly looking canal stenosis wonderfully well. You see multi-level, 2 level, 3 level, we operate 4 level, 5 level together. This is very easy to do actually. So you see here 1 level, 3 level, another level also free of cost we do. 4 level hemilaminectomy is quite possible. You can see the scans, how nasty looking. Any scan now, we have found a cure. Any bad looking lumbar scan can be treated by biportal endoscopy, whether you fuse, whether you don't fuse, whether you do foraminotomy. 99.9% cases, other than any revision or screw breakage, we treat by biportal, and that is what this is growing very, very fast. The corporate hospital is very happy because so many patients are coming, and they're happy to pay because they want their cure. They are sitting, this patients who are very old, their son is sitting in US, they want a solution. Then solution is biportal, because I'm able to see that we are able to cure a lot of patients without any issues. Sometimes suppose the patient have some phenomenal work, that also can be done because we are doing surgeries with the midline technique very, very fast. So you see another case, how badly it is stenosed. So we started doing the decompression. So I just want to show you the last picture. So last picture is the CT scan. You can see it is a CT scan where you'll see as if the open surgery was done. Now fusion and other level decompression, hemilaminectomies were done. at multiple level.
L3,
So
and
it
you
just
see
looks like a open
post-op CT
surgery
scan. You can
outside.
see
So inside it is open surgery, outside it is
post-op
ultra
CT
minimally
scan. You can
invasive
see
surgery.
at
Patient says a very
function,
small incision, goes
and
home
you can
next
see
day, and
3,
but
4,
inside the work
5,
is very
5.
adequate. So that was the question, whether endoscopy was able to do adequate work. So this is the example how endoscopic biportal surgery can do adequate work, but still be the same ultra minimally invasive surgery, small wound like the patient expected. So this is a severe canal stenosis. We have done more than 500 severe stenosis now. This is an initial report. We will come up with the highest volume numbers with the multi-level canal stenosis, but you can see the score improvement and the initial results for this multi-level canal stenosis. We have published it in Asia Journal of Neurosurgery, reimagining UB with midline biportal approach with under the cave work decompression technique for multi-level canal stenosis. This is a beautiful work. If you watch my videos, surgeries are really fast. So we can do a lot of work with this midline.
So we are going for a midline biportal endoscopy. We palpate the spinous process, which I consider as the midline, and we have 3 lines. One is a midline, left midline, and right midline.
So this is based on
here within
Namaste
the
point, as all
view of
Indian, everybody
the
wish
Namaste
us
point,
with
which is the
Namaste.
highest
So
point.
we have
The
described it as a
segment
Namaste
on
point.
the
We don't take
lateral
any
view,
other
which
landmark
marks
other
the
than the
and then
Namaste.
portals are created on the Namaste by 3 centimeter apart.
And I have
keeping the
reduced the
Namaste point
size
at the
of the
center, the
incision to
fascia is cut,
very small, because
and
with the
the
specific
triangulation
dilators
is
we have
made.
designed,
We
we are
make
able
small
to
serial
make it
dilators,
very
which
small.
makes
This
the
is
incision
actually a
very
game
small, and
changer.
serial
But
dilatation is done.
initially
This
it
is a
takes a
muscle
lot of
splitting
time to
lesion,
understand the
which
technique.
does
It is
not need to
difficult
cut the
initially,
muscle,
but
and
once
then
we
we have
master
made
it, once we
endoscopic
master
portal,
the
which is
drilling
the upper
techniques, once we
portal.
master the corner
So
work,
similar
then
way
it is a
as
very
in at
easy
the
PG
Namaste
solution.
point,
Once
no
the time
triangulation is
reduces, you can
needed in
start
this
doing
process. Only
multi-level canal
port
surgery very nicely. There is another case with patient had now patients are using chat gpt. Somebody told me ki I am good at tubular, whether why should I move on to biportal. I said, see, this is the choice. Now patient are coming with a choice. They will choose something better. They will choose something which is coming showing by the chat gpt. So now a bloodless surgery or a bleeding wala surgery, a painless surgery or painful surgery, definitely people will always choose smaller incisions, smaller work, and better work. So a smaller work which is producing result, which is biportal. So you can do 4 to 5 level, 6 level, whatever level you want with biportal. That is the magic. So this way, removing the disc, the patient said, now patient come with everything, with doctor shopping. They will come, you sir, I have a disc on the left side and I have a calcified disc on the right side. Okay, I started searching it. On the contralateral side there is a rock. So in the versatility of UV, you can access any corner very beautifully. So if you see in the video, sorry, in this video you can see at the end of the procedure. So we can go to the corner and decompress this root. There was no exiting route or traversing route on contralateral side, but with this technique I could fish out the traversing route at the end of the surgery. You can see at the end of the surgery you will get the traversing route which was hidden by the calcified part. So that's a traversing route which was visible and compressed by the calcified part. So we have devised this Namaste point. Namaste point is the highest point on the lateral view of the X-ray, which is known as, now looks like Namaste. These two hands, if you join together, looks like Namaste. That's why I call it a Namaste point. We also add foraminal work. So people have started asking, what about the foramen? So we said we do direct decompression. Other than the indirect decompression, we also do direct foraminal decompression. We watch the central canal is decompressed and the foraminal roots are also decompressed, so that we add it to specific cases when the patient says I have a predominantly right-sided pathology or left-sided pathology. So this is how we do. So this is known as foramen. So we use a 0-degree scope, we instead of a 30-degree scope. So this is a 0-degree scope where we are using, and this is the surgery where we are doing end plate preparation for fusion. We have started doing dual cage fusion with fusing with 2 cages. So 2 cages, 2 screws. That's the norm. 2 portals, 2 screws, 2 cages. That is what fusing very well. So the implant burden on the patient is reduced and patient goes home wonderfully well, because somehow the patients are more comfortable with 2 screws. That is what socially we are seeing. Patient are saying rather than 4 screws, we are feeling more comfortable with 2 screws. So you can rotate this cage inside and you can do all the maneuver. You can prepare the end plates very nicely without a direct visualization of the end plates. So these are the dual cases. So I call it ultra MIS because only four portals or two portals are needed for the screw placement, and case also goes through the same. The discal preparation, whenever we talk about the discal volume, the more you prepare the disc, the more volume is created and more space is made for the fusion. So you can see we have injected a dye inside the area, so you can see how much space was created by the endoscope, and the two cages are here. So you can see the height augmentation possible because from here to here. So fusion also can be done very well with biportal endoscopic spine surgery. From here to a lordosis, some people say T-leaf doesn't produce lordosis, so you should go for O-leaf. But here, because you can put the case anteriorly with a wonderful discal preparation, you can augment, make those lordosis possible very well. So disc volume, one volume of the disc we have calculated on the MNI basis, which is comes around 18 ml. So we have almost removed 10 plus ml of the disc, and you can see the ALL fibers through the scope which is present anteriorly. So you can put the cage anteriorly and augment those work. This is another work where the corpse angle and orientation is very well done from 16 degree to 30 degree, making this lotus is corrected because the cage is placed anteriorly. This is unilateral screw fusion. How you see the how solidly the patient has fused with unilateral screws. So this is Grand Canyon sign which are devised because in some of the cases the end plates are not parallel. You need to drill those end plates to make it parallel, like we do in a ACDF surgery. You have to drill the end plates. This was not visualized in open surgery or microscopic surgery. That's why we never know. We call it a Grand Canyon sign. And another thing, I'll show you the post-operative scan. You see how much bone work was done here, and you see the intradiscal packing of studying the case, place with multiple bone forming material. So the interdiscal space is studded with many of the bone forming material, making it better fusion. So we are getting wonderful fusions at the end of the procedure. This is and the spondylolysis, and we do a wonderful decompression by decompressing the thing. Whenever the opponents or proponents of people of Olive say indirect decompression is enough, so what we could find is the exiting route. There are a lot of scar tissue. That is why patient post surgery in an indirect decompression gets relieved of the back pain, but the leg pain still there. This is because of the scar tissue. So we can directly see the scar tissue and do this adhesiolysis, making this root um, to have a better radiculitis free post-operative period. This is a white tissue which we remove. Then we go inside. We could see this. Once we go inside, we see could this the walls of the end plates are not parallel. These are uneven, making it a space where we can see this. We call it a Grand Canyon sign because the end plates are not parallel, so we call it a Grand Canyon sign. This looks like the wall of the Grand Canyon, so we go there and drill it. So this is what it looks like, a Grand Canyon. So this is the end of the surgery and procedure. So these are also published in Optimizing Lumbar Interbody Fusion with Dual Cases. This is a good paper, people can read it. So these are all foraminal augmentation done by Biportal. There are a lot of work. We have developed this hanky in the pocket technique of dural repair in this Biportal endoscopy, where we put a larger size lioplant graft to put it inside. So anything can be done. We also have devised the suturing technique endoscopically. So this is, we call it the hanky in the pocket. So we are suturing, you see, endo suturing also we have mastered. So we can put and do the closures very well. So this is what is we can do. This is a monoportal scope and this is a biportal scope. You can see my scope has gone out of the foramen through the foramen, and you see the monoportal scope is stuck at the midline. So this is what the advantages we get. This is the hanky in the pocket technique we have devised for dural tear in lumbar canal stenosis. People can go through this. This is a wonderful paper, and we do a lot of teaching training program in biportal endoscopy. A lot of doctors come here and get trained in the novel technique, and there we don't see only the technique, we see the pre-op evaluation and the post-op outcomes. And this is what every patient is so happy. Most of the patients are elderly. All my patients, mostly 80% of my population is more than 50 years of age, was suffering from canal stenosis. We do a lot of discectomies also, but these patients These are the patients who are sitting at home since 10 years, 15 years, not going for surgery because we offered them an open technique and a very difficult way to cure. So what we have provided is an easy way to cure, and that is why patients are coming to us. So they are my team and my hospital, and this is my YouTube channel. Everybody can follow this. I put every day, almost every week, with 2 to 3 full unedited videos, so that people can, most of the doctors, they put small videos of the unedited videos, so people cannot understand. But with this we can definitely make people understand how the biportal surgery is done. Thank you so much. Thanks for the patient listening.
Thanks a lot, Dr. Atmaranjan. Thanks for giving a fantastic talk. I hope many of neurosurgeons from Maharashtra will take this up, and they'll come to you for fellowship, get experience, and start their own work. Thank you so much.
Thank you, sir.
Dr. Dattatreya and Dr. Chandan are here. Good evening.
Yes, yes. Good evening, Ranjit. And can you hear me?
Yeah. You're audible.
So I think it was a fantastic lecture by Atmaranjan. I am just amazed to see what can be done from small incisions on the back like laparoscopy, and he has also devised different names for that. Is very interesting. So my can I ask question, or we are going for the second?
I think we'll go through
At the
second
end?
presentation, and then we'll have a round table.
Okay.
That's
fine. Yeah,
right.
that is fine. Yeah.
So I'll invite next speaker, Dr. Verma. He is practicing in Rishabh Hospital, Jaipur, and National Institute. He has a big Maharashtra connection, or two connections, I can say. One, he did his undergrad from Nashik, and second, he has worked with Dr. Patkar. So welcome, Dr. Verma. You can start. You can share your screen and start your talk. And thanks for joining here for MCNS.
Good evening, everyone. Am I audible?
Yeah, you are audible. Okay,
Yeah.
Please go ahead.
Yeah, thank you. Good evening, everyone. Thank you for giving me this opportunity, MCNS, for presenting my work here. And I'm grateful to Patkar sir, Majumdar sir, Ranjit sir, Sarang sir, Shivshankar sir for considering me for this presentation. So here I'll be talking about the hemostasis in UB. So whenever we start with doing UB, the foremost complication which we fear is bleeding inside the cavity because it's a closed small cavity. Right. So why bleeding matters in UB? Bleeding matters because it destroys the orientation very rapidly. As it being a water medium surgery, as soon as the bleed happens there, the blood, it absorbs the light, causing an instant red screen, so that everything becomes blurry and bloody there. And it soon pushes the surgeon into panic mode. And as it is a small cavity surgery, so the visualization is the foundation of safety in UB. And most of the complications happening in UB is when the vision is not clear. No, you are not able to orient yourself. You're not able to orient the instrument you're putting inside it. So why bleeding is different in UB? Because it is a bottom medium surgery, so it gets magnified. Even because the corridor is so small, so it amplifies the disorientation happening there. And continuous irrigation, it actually marks the blood loss inside the UB surgery. Venous congestion and poor outflow can lead to severe venous congestion and increase in the bleeding there. Also, the red screen, it creates a cognitive overload over the surgeon and a block, and the panic surgeon can take decisions which can ultimately hamper his surgery and cause complications. So what are the common bleeding sites which we encounter during the surgery? So first is the skin and the paraspinal muscle. And next we come to the bony part when we do the bony drilling, that is the cancellous bone of the lamina and the facets and the spinous process. Then there are segmental arteries which is coming from the facets and uh, uh, the lamina. And also there is a diffuse hidden blood loss, which I'm going to elaborate further. So to simplify the types of bleeding, how to identify the bleeding source from where it is coming. So muscle bleed, it usually comes out from the incision area itself, or it comes from above along the scopy port or the working channel. The bone bleed, usually the cancellous bone, it oozes more. We see such bleeding more in the younger patient as compared to older patients because the vascularization is less viable in older patients. The venous blood, as soon as we remove the ligamentum flavum, we encounter the venous plexus, the Batson plexus. So we identify the bleeding there. It is usually non-pulsatile flow of blood. When we encounter arterial blood, it is bright, very pulsatile, and it is jet-like there. Hidden blood loss, it is hidden. We don't happen to comprehend the bleeding there, but post-operatively, when the patient complains of dizziness, giddiness, when we make him or her stand, and when we do a check hemoglobin, the hemoglobin comes to be really low, then we come to know that yes, there was a hidden bleeding loss. Yeah. So these are the few videos indicating how the bone is bleeding here, and this is the epidural bleeding which we encounter when we identify the natural cleft in the flavum. So what are the, coming to the risk factors for bleeding? Definitely the advanced age and osteoporotic spine, patient already on anticoagulant, antiplatelets, in obese and thick muscle patient, we have to traverse a thicker area. So the propensity of bleeding in such patient increases. Poor positioning. If the abdomen is not free, intra-abdominal pressure, it rises and it can lead to transmitted pressure in Batson plexus, tending to increase the bleeding from the veins. In cases of severe stenosis, there we encounter engorged veins. So we have to proactively go and coagulate those veins to minimize the bleeding. And in multi-level prolonged surgery also, it is one of the risk factor. So the bleeding control of bleeding starts not just at the time of surgery, starts before the surgery by optimizing the patient for the surgery. Like the routine, what we follow in our routine surgery, like review of the INR, correcting the platelet coagulation profile. If patient is on any antiplatelet, anticoagulant, that we have to mitigate before the surgery. We have to study the MRI and CT scan carefully. As I've placed an image here, there is a severe canal stenosis here. As you can notice, there is markedly enlarged epidural veins we identify here. So we have to be mentally prepared before going inside what we are going to see when we remove the flavum, what we are going to face. Also, we cannot win the war without any weapons. So our weapons like the RF probe, the plasma, and the hemostatic agents should be handy with us. Also, if you plan a trajectory preoperatively, it also helps to minimize the muscle trauma and bleeding. Now coming to the positioning point, it is the routine prone position. No breaking of the bed is required. I usually ask my ancestors to keep the mean arterial pressure between 60 to 70 mm Sg. The abdomen should be free of any compression. The PEEP should be below 20. Also, when we start with the UB spine surgery, draping is one of the issue with which we fight a lot. Usually the surgery in the initial period, it takes longer time, like 2 hours, 3 hours, it may last. And the saline tends to seep inside the drape and making the patient wet. And in the cold operative environment, the patient can land into hypothermia and the coagulation cascade can be activated, leading to further bleeding. So irrigation is the fundamental hemostatic tool here, which we tend to avoid because the outflow is more important than inflow. If the outflow is there, the egress of saline is there, then even the small or little blood loss can be washed off through the saline. Also, if the outlet is not working well, so the intracanalular pressure, epidural pressure may rise further, causing congestion of the veins and leading to further bleed. Now, creating the portal, we have to be sure that we don't cut the muscle. We have to split the muscle with the trocar there. Adequate fascial opening should be there so that the fluid is not impeded while we operate. We have to avoid muscle strangulation at any cost. We have to maintain a dependent flow, like in the previous video you're seeing, that is called as a fountain sign, where the flow is naturally coming out through the exit port. And mind you, I'm not using any kind of pump there, only gravity is working there. So muscle bleeding can be easily controlled by tamponade by the thumb. You can just compress the point from where the incision is given, or inside when you notice any muscle bleed, you can directly coagulate that bleeding. Even warm saline or saline loaded with adrenaline can help for a brief time. Now coming to bony bleeding. So the spongy bone is the culprit here. It usually leads to bleeding. Before progressing further, I usually go and proactively control the bleed. This can be done just by compressing the head of the diamond burr or your Carrison burr. It can be easily done. And in some cases, you can even apply the plasma or RF there. In cases where the bleeding is torrential from the bone, as shown here in the video, we can also apply a bone wax directly on the bone with the help of the drill to stop the bleeding. Now coming to the epidural bleeding, so we have to be aware that the venous plexus are there on the operating field present. So it is a valveless system and it is congestion prone. In case of severe stenosis, huge engorged vein, they come into our bleeding field. We have to go proactively coagulate those veins. If the bleeding is diffuse, we can even use a cotonite to tamponade the bleeding point. When we are over the dura, to coagulate this bleeding, we have to keep in mind that the RF coagulation is kept at the minimal. So my coagulation here is just at level 1. In such cases, we can also apply Flowsil or Surgicel to stop the diffuse bleed, and after a time, we can remove that thing. So in this video, it is depicted like Surgicel is being placed to a diffuse bleeding area. Surgicel has stopped the bleeding. We have to keep it for some time. Once the bleeding is completely stopped, Surgicel can be removed. Coming to the arterial bleeding point, as I've already mentioned, it is bright pulsatile flow. Immediate identification is very critical, and we have to identify the bleeding source before coagulating the point. In case if you are not able to identify the source of bleed, you can put a cotonite there, temporarily tamponade the bleeding point, identify, clear the field, and then you can go and coagulate the point. If you are unable to do it, don't hesitate to convert to open surgery. Now coming to the red screen management. The first and foremost step is you do not have to panic. You have to stop every movement you are performing when you are unable to visualize your instruments or your orientation is completely lost. You first have to slightly pull the scope back, identify the orientation, then you move closer to the bleed. As shown in this field. Also, you can raise the height of the saline port so that the flow of the saline increases. First, you have to identify the bleeding source, tamponade it with the head of RF, identify the bleeding source, and then easily go and coagulate the source. No random movement inside the cavity. So what are the recommendations for RF when we are using? So RF should be at the low setting. If you are doing work above the bone, then ablation can be kept at up to like 6 to 7 and coagulation can be at 2. And when we are working on the epidural space, before removing the flavum, We can do a coagulation of 1 and ablation can be kept at 3. Near the dura, ablation is not recommended and coagulation can be done at 1 level. Now coming to hidden blood loss. So hidden blood loss, almost 30 to 50%, it remains underestimated. Irrigation, because it is continuous water medium surgery, the irrigation, it washes away the blood with it, and we don't guess how much bleeding is there unless and until post-operatively we get a low hemoglobin patient complaining of lightheadedness, giddiness while standing and all. More common multi-level surgery, and we have to do a hemoglobin post-operatively in cases of prolonged surgery and if we are suspected bleed. Now, what common mistake we do in UB hemostasis? First of all, if a pump is used, we increase the pressure so that tamponade effect is there and the bleeding will stop. The outflow is not good, then this is a problem there. Blind RF coagulation is a strict, not advisable. Aggressive suctioning is not advisable. Excess muscle dissection to create the field, create the port is not advisable. The Swan space is a potent space, and once your port is created nicely, your fluid egress is created nicely, it will automatically give you a lot of space to work inside. Now, what are the complications of poor hemostasis? Definitely neuroinjury, incidental durotomy, postoperative hematoma, and prolonged operative time. Also, the visualization is gone, so the surgeon gets fatigued, and there is a need for conversion to open surgery. Here in one of my cases, in initial cases, I happen to have a dural tear over the traversing root here. Now, conversion is not a failure. You have to know when to convert to open surgery. So if the visualization is not safe anymore, your orientation is lost and the bleeding is torrential, it's not being controlled, or patient has landed into instability, don't think twice, convert to open. Now coming to cognitive errors during bleeding, once we see a red screen, because it is in very short time, the screen will completely turn to red. You won't understand where we are going, where our instrument is, where my camera orientation is. So the panic, that time the panic movement happen. We tend to move the camera system, then we apply the RF randomly. We start chasing the bleeding blindly because it is closed cavity. Sometimes the blood goes and it turns back from another source. So we try to identify, we think like the bleeding is from the right side, but actually it is coming from the left side or from the opposite side. The surgeon, when operating, when the bleeding happens, he tends to use RF more to control bleeding randomly. And whenever we are under stress, we have a tendency to make a poor decision. So this is the algorithm which I usually follow whenever I happen to have such cases. First, go and identify the source, tamponade with the cottonide, improve visualization, increase the flow of saline, rise the level of the saline bottles, tamponade with the cottonide or just the RF head. If the bleeding is not stopping or it is a diffuse bleeding, you can go apply a topical agent like Surgicel or Abgel there. Reassess the anatomy, reassess, orient yourself. And if you are able to identify, go and coagulate it. Otherwise, don't hesitate to convert to open. Now, these are some practical operative pearls. The hemostasis begins before the bleeding starts. From the pre-operative thing, when we position the patient, we have to talk to anesthetist also. Free flow of saline is the fundamental for clear field and good hemostasis. Diamond burr, it helps reduce the bleeding. We have to keep calm. We don't have to react when we get a red skin or we get a diffuse bleed. Thank you.
Thank you, Abhijit. Thanks for a detailed roadmap how to avoid and stop bleeding. Because in endoscopy, we are always worried that surgery is going on, everything is smooth, then suddenly the bleeding starts, and then you are lost, and many times you have to convert it to open, or you have to just stop wherever you are and come out. And it's quite frustrating. Thanks a lot. I think now we'll take questions from the audience. And first, comments from the experts. Patkar sir, Muzumdar sir.
Yeah, Sushil first. Is Sushil there?
Can you guys hear me?
Yes.
Yeah,
Very good.
yes sir.
Yeah. Fantastic. Means it was an eye opener for people of my. I'm a dinosaur in spine surgery, but definitely Dr. Dash and Dr. Verma, they have opened eyes of many people like me. And I've been going through all this. This evolution of spine surgery always has been reduction of the injury to the muscle. Every time when microlumbar came, or first I began when Dr. Venkshar used to do L4-5 laminectomy for a L4-5 disc. Then it came down to hemilaminectomy, then fenestration, then Dr. Ramani did a microlumbar. And first time when I went to assist Dr. Ramani, I saw, and he was struggling. He had put the headlight, and I went after the operation, got my eyes examined because I didn't know what he did inside and removed the disc because I was used to a wide laminectomy by Dr. Venkshar. So gradually the evolution has been the decrease in muscle injury. However, the lamina and the ligamentum flavum have absolutely no role in the generation of pain. But still, lamina is removed and the ligamentum flavum is removed. In canal stenosis, definitely ligamentum flavum is important, though Dr. Ramani had published in Newcastle a paper that ligamentum flavum is blamed unnecessarily. It is the ligamentum flavum which buckles because of the disc settlement, and there is nothing like hypertrophy of the ligamentum flavum. Of course, over the years, I have don't agree with that concept. And I was very impressed to see Dr. Dash show his surgeries. And one question which I have for Dr. Dash is that I have been trained I began with the entire transition, pre-CT scan era, then CT scan, then MRI. We were programmed to remove the tip of the of superior facet to decompress the exiting root. Removal of the tip of the superior facet was mandatory if you want to treat canal stenosis, or the patient's claudication is not going to improve. He rightly pointed out that with uniportal, they don't decompress the exiting root. But one of the factors which causes the exiting root compression when the disc settles is the tip of the superior facet. I don't know whether he pushes for removing the tip of the superior facet. In Dr. Verma's presentation, I was very impressed. Dr. Verma, when he came to me from where he has climbed and where he has reached, I'm very proud because those days, I was still doing something with the routine neurosurgery. And I told him that the future lies in endoscopic spinal surgery, and he took that cue. And I have no role in teaching him endoscopic spine surgery, though later on I started doing a little. What I want to know is that which cautery, the parameters which he showed, he should tell which cautery he uses. And what is the parameters we said? You keep the coagulation and ablation, but that must be cautery specific. No, it must not be generalized. And in his flow chart of bleeding, I was very happy. But there are two, three things which he did not put up. One is that first blame the anesthetist, then blame your assistant, blame the light, and finally pray to God. And that is the step. And then finally ask yourself, why did you decide to operate this patient? But I was impressed by what he has shown, and he really did it very well. Thank you very much.
Yes, I think Sushil, you gave a very lucid comment because I'm not that much into total spine surgery, but I was amazed by Dash's presentation. It is like at Sion Hospital when I was there, I promoted endoscopic spine, but with Sagar, but it was the Destandu technique. And what he mentioned just now about this biportal, which appears to be like what we do at open surgery, but now it is like a minimal access and maximally invasive from inside. But I think what he showed was very. It appealed to me actually that concept, and I think that can be carried taken further. People can learn from him. He can make it more uh, more amenable to and available to all. And what Sushila said, I think you have given more technical points to that, so I would not add to that. But I was, and obviously Abhijit's this thing about the standard what we do under open for achieving hemostasis, like you just control saline irrigation, identify the point, coagulate, coagulation parameters you have already mentioned. But I think both the presentations were very good, and I think these are the stepping stone to endoscopic spine. So even though I am not, I like you only, I am very much fascinated by the endoscopic spine, though I have come a decade, a decade more late into this. But I think this is the future of spine surgery if it
Yeah.
gets more evolved.
The,
Thank
the,
you.
the, prog- the progress of spine surgery or any surgery for that matter
Yeah,
is
yeah,
self-annihilation.
yes,
We have to progress to make the operation smaller and smaller and
yeah,
eventually do away with the operation and find
yeah,
a non-surgical answer for a surgical
yeah,
problem. And Dash and Abhijit Verma have shown it
yeah.
very beautifully.
I
So
have
it
one
is,
question, Sushil. This has occurred to me. Now, what about for a multi-level canal stenosis and when you know the posterior fixation without decompression, which Dr. Goel proposes. Now,
I'm not,
how does this match with the biportal that he is saying that internally it decompresses, which is it is a decompression without destabilization. So I think what Dash's technique is, does it appeal that you have a decompressed spine root in contradistinction to just fixing the spine and then reducing the mobility and reducing the pain. So how do these two go
see,
about?
the question is you have to decide. I personally would go with Dash rather than Goel.
Yeah, yeah,
You
I
have to
got.
decide for yourself whether compression is the problem or whether instability is the problem. If compression is the problem, we know we have seen so many patients. Of course, there's a radiological and clinical mismatch in spine surgery in more than 50% of the patients. You can have patients with severe canal stenosis on the MRI and no symptoms, and patients can have minimal compression and symptoms. But when it comes to it, people have done experiments like putting a Foley's catheter in the spinal canal, inflating the balloon, and recreate the symptoms. So that comparison is important. There is no argument in my mind. I
Hmm.
need more evidence to believe in Dr. Goel's theory that
That it is
without
instability.
decompression, you can treat a patient. I don't know what Dr. Dash has to say. Let us hear
Yeah.
Dr. Dash. We are
So
not the operative.
to add to that, what Dr. Goel's theory is that when there is such a multi-level compression and whatever the compression elements, it is always an unstable spine. So
I
the
don't agree
treatment
with
is
that.
so is it like that?
No, 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 no. I feel that canal stenosis is a keloid. We all go through the phases of disc degeneration, instability, and auto-stabilization. And sometimes the auto-stabilization is excessive, and excessive auto-stabilization is like a keloid. The scar, the ligamentum flavum hypertrophy, the canal stenosis is just excessive stabilization by the body. And therefore, the excessive stabilization results in spinal cord and root compression. So all of us go through disc degeneration, micro instability, and auto-stabilization. It is the auto-stabilization in some patients becomes excessive. When you get a young patient with disc, the problem is not instability or the problem is not canal stenosis. It is the disc which comes out, there are two components, the inflammatory component and the compression component. Therefore, so many patients become all right with steroids. So many patients
Yeah,
now. So this theory that only instability is responsible is little difficult for me to digest at
yeah,
this point in
yeah,
time. Maybe Dr. Goel's theory might be correct, but time will prove it. Dr.
yeah,
Dash, I want your comments.
Sir, whenever we try to go through the same thing, suppose there are two techniques we discover. We discover only fusing, and other thing is only decompressing. For fusing, the surgery is actually big. Suppose we are dealing with a 80-year-old lady and we are planning a fusion. She is going to live for next 10 years, and we are trying to current her degenerative spine to straight spine. Already the muscles are squeezed, and we are trying to align the muscle at the age of 82, and she suffers a lot of pain post-operatively. At least the next 10 days are hell for her. After that, maybe some magic is happening or something. But now, if you we discuss about the decompressive craniectomy, there was a process started where we did cystonostomy and kept the bone flap back. It never worked. Only worked is only decompressive. It state that the key surgical technique for all head injury patients. If you do not decompress the neural structures anyway, the conduction is like a pipe. The current flows through like a pipe. We compress it, it is not going to flow. Whatever we do, any direct or indirect, if you can decompress it directly, very nicely, why to go for any indirect decompression and wait for 1 year to have a negative decompression? It is too much for the patient. We want to give the patient, that is why patient fear for spine surgery. We have to give our population a easy solution where they can walk in the evening, go home on the next day, and they don't feel as if nothing has happened on the body. No blood loss, no pain. No pain is the only thing which keeps them away from the surgery. If you're going to say them, we are putting 10 screws, we are stiff, you cannot rotate, you are so back, adjacent segment developing after some years. We have somehow underlooked the power of direct decompression over indirect decompression for decades. Indirect decompression, always screw pull out, screw breakage, rod breakage, patient coming again for another up, and you keep on piling the screws up and go. Some people are piled to the cervical spine. We cannot fuse so much of work on so old patients. Anyway, young patient, you are fusing one level, okay, but multiple level fusion screw, and all patients of Indian population, they sit on the floor. All patients have osteoporosis. Every screw is going to come out, and the rods is going to break. So we cannot keep our population to go through a difficult surgery. We have to give them an easy surgery, which is a decompression. So now if you come to decompression, that is open decompression. If by a endoscopic technique, if can do the open work inside but still ultra minimally invasive surgery outside, then the patients are really happy. I have been doing this surgery since last 4 years, every time, and at this age we are operating more than 100 cases a month. We believe in Odisha, and where these patients are coming and how they are getting treated, but whatever post operative we are seeing is next level. I think this cannot be matched by any other technique. Actually, it is producing results. Maybe
What is
my
Odisha?
voice won't reach to a
What is
Atmanajan, are you?
Odisha?
Yeah.
What is Odisha?
Odisha.
Odisha
Odisha.
is Bhubaneswar, sir.
Oh,
Bhubaneswar.
now I want to know,
It was,
Dr. Das. Dr. Das, I
it
was
was
very
Orissa,
impressed.
not Odessa.
Odisha.
What I liked in your talk, that you said that one additional level I will do free. Means you are charging per level of surgery. That was impressive. You said that one level we gave them free, additional level. So I was
Das has
shocked.
given a new idea. Das has given a new
Yeah,
idea
yeah,
to
yeah,
Kotkar, sir.
yeah.
Sir,
Just
Kotkar,
like
sir will
putting
set a new
a.
standard in Pune.
Atmaranjan, I want to ask you, do you check for instability in all patients? Do you confirm anything,
Sir,
flexion,
every
extension?
patient, we do four test. One is a MRI, which is a complete foraminal and
Yeah.
central canal analysis. Second
Hmm.
is a CT scan must for all cases to understand the foraminal and SAP overgrowth. As sir asked, whenever there is a concavity, suppose most of the patient are Degen scoli. Suppose the patient says, see, my both the limbs are having claudication, but my right limb is much more painful than the left limb. And if you analyze, there is a scoli on the right side. We do foraminotomies by removing the tip of the SAP, because all these elderly bones are auto fused. You don't have to break it and again fuse it. So it is already, God has fused it. There's no need to add and break it and fuse it. That's too much for the patient. So what we do, foraminotomy is additional. Foraminotomy is outside the foramen, we go and take out the tip of the SAP outside the facet. So that is called as para UB or foraminal UB, that we add to the patient along with the central canal decompression. In the central canal, if the stenosis is very severe, we do hemilaminectomies, multiple level. We know the bones are very strong. Till now, we have been doing since 4 years. There is no progression of scoliosis. Patients are not coming back for evaluation either. It's a very amazing thing, because we call them repeatedly to write down papers. Some people comes and some don't come, even if you ask them for free consultation. So we believe it is really working. My voice may be not reaching now, but after some years, everybody will be moving to this kind of endoscopy after getting the results.
You are already
Sorry,
famous
can
and followed.
Abhijit,
Don't
I'm
forget.
waiting
sorry,
for
can I?
Abhijit's answer. Abhijit, your answer as to which cautery machine you use. And what I liked is that you plan for the bleeding from beginning of the operation, which was very impressive. And I was very happy. But see, what I when I did, for transforaminal surgery, it was, it was very normal to increase the pressure of the water whenever there was bleeding to clear the field, and then gradually decrease to find where it is bleeding from. But you are not recommending increasing the pressure, and you don't use any pump. You just use the saline. What height of saline do you use? How much high do you keep the saline bottle? And how many bottles of saline do you use for a single level discectomy, or say two level canal stenosis?
Sir, to start with, the height usually what I keep is like I am 5'8" in height, so I just keep it just above my head, this thing. But the recommended height is 100 to 150 centimeter from the bed of the patient, from the back of the
Which is how
patient.
much? Which is how much? How much? 6 feet to 7 feet?
It will be around 6 feet, sir.
6 feet. Okay.
Yeah. And coming to the RF setting, now I am using the bond system here, and which I showed here, it's an Arthrex system. So as soon as you put the point RF there, the setting automatically comes down to 1 and 2 in the coagulation and ablation thing. So you need not care about setting it there.
Okay, okay. And see, the argument against endoscopic surgery was always the cost of the time of surgery, how much duration, which I'm sure reduces with your experience. And the other thing was the costing, because this RF, and you require the endoscope, and you need to book the all these gadgets. So when you do an open microlumbar discectomy, which is done by most of the surgeons all over the country or in the world, vis-a-vis endoscopic disc, how much is the difference in costing for the patient?
So, sir, coming to the RF wand, usually the standard companies like Bonds and Arthrex and all, the RF wand, it costs around somewhere like 25 to 30,000. And the working life for like bonds I'm using, it is up to like 40 minutes. So initially I happened to use a single wand for like 2 cases, because like my surgery used to be for longer duration, like 3 hours, 3.5 hours, 2 hours. But as my surgical time is reducing, I'm able to use same wand for like up to 3 to 4 surgeries. And coming,
How many cases you have to do before you reach this stage?
so at least 50 cases, like in my experiences, to be there. And of course, like to reach to like 3 minute thing, I think more than 1,000 cases, like Dr. Das has already done.
That RF Kusum is the way of assessing the chance of complications and the duration of surgery. They say that 35 cases to 38 cases, this was published by Chen from China, that 35 to 36 cases, 38 cases is what is sufficient. Do you accept that? That by 35 to 38 cases, most surgeons all over the in smaller centers can master endoscopic disc surgery, or it requires more time?
No, sir, it requires more time. It depends on the personal ability also. Like a younger child, a surgeon will be more depth with his like bidexterity also matters a lot. So like after like 20 cases, you actually get the orientation, where you are going, how much SAP and IAP you are removing, how much phlegm you are removing. And after that, like when you reach a 50 cases, at least 50 cases, then actually the patient starts like improving after your surgery.
How many cases you converted to open in the beginning
So
from endoscopy
almost like 10 cases I have to convert into open.
up to now? That's all. That's very small.
Yes, sir.
And what about Dash, Dr. Dash? Now, of course, Dr. Dash is the master. Dr. Dash, I want to ask you how many cases you have converted to open, or do you still convert cases to open anytime, or you never require to convert them to open?
Initially, I think 3 cases in my career totally we have converted. I was very determined that if I have taken money from the patient, I will never make them down. So we try. That is the biggest motivator. If it takes time also. So that is how we designed this dural repair techniques, suturing, and everything. So the actually the cases which were we had converted, and the cases we were not converted had much cases we are not converted had much better outcome than the patient who are converted. So
I
then
see.
we so because same surgery and you again open up the everything becomes very messy for the patient. So so we are not converting anymore, sir.
Very good. Now, Dr. Mohanty, where is he gone? Mohanty, I'm just doing the talking. Where have you disappeared?
So I'm here. My one question, I think word of appreciation as well as a word of caution. Word of appreciation is to surgeons like Dr. Das for the amount of cases and the volume of cases that they do. But the word of caution is uh, probably the, if you talk to your peers, what we find out is that the dropout rates for people who do spinal endoscopy is probably the highest. So I
Yes.
would say almost 1:1. So for every surgeon who pursues endoscopy spine, one out of two people who pursue endoscopy spine in the beginning, only one of them keeps doing
Going.
endoscopy spine and the other one drops out. So I think I first of all appreciate the perseverance of both Dr. Verma and Dr. Dash to go from 8 hours to 3 minutes. So that really tells you the amount of dedication and time that they have put in. So that's my word of both my word of caution and appreciation are mixed into that. The other thing is that whenever we see at least for the beginners, whenever we see videos of experts like Dr. Das here or Professor Patkar for CVJ cases, we feel that the surgery is easy. So that is not how it is. Because we see a refined technique, we see a master at work. So and for us, for someone who is trying to say, if tomorrow I try to pick up UB, I have the picture of the video presented by Dr. Das in my mind, and I try to think, why am I not able to do? Why is it getting so hard? Why my screen is getting red? These people are doing it 5 minutes and 7 minutes, and for 1 hour we are still not getting our triangulation correct. So that kind of struggle is also very common. So I don't use UB. I use the easy go technique, which I feel is easy, which works in my hand. So that is just one comment from my end. The other question that I had to both of you is that whether you do UB under local or under GA, or both, or depending on the case.
Naturally, most of the patients are elderly. So our anesthetist, I don't know what is it is right or wrong, but anesthetist say if it is GA, then they are very no, no. We did a lot of cases under regional anesthesia, but whenever you say I'm cutting this, cutting that, they will get this anxiety attack. What you are cutting? Is it my nerve? And second thing is, some people after some time, they will, old people especially, they will start feeling, because it's a very claustrophobic environment in the OT. So GA, they are tolerating very nicely. Most of the patient after surgery, if you ask them, did you feel any pain? They say, no, we didn't feel anything, as if the surgery was not done. So which is a good thing. That is why we are following this. And our anesthesia says, well, most of the patient had some cardiac issue, something. So it is more control under GA, that they believe. So I leave it to the anesthetist, because my point is the patient should be happy, patient should be pain free, patient should be complication free. That is what they decide the best way possible. Even doing on a local anesthesia, maybe there is some pain in the patient, you keep on poking them multiple times. More comfortable is GA. But for people do, we also
Yeah,
have done
yeah.
some
So
cases.
the reason for me asking is that we always try to compare the different endoscopy techniques, and I think the main selling point for transforaminal surgeons is the fact that they routinely do it under local anesthesia. And somehow the interlaminar endoscopists, we have kind of fallen behind in terms of doing the surgery under local anesthesia. So that was the point. Even I do most of my cases under general anesthesia, and my anesthetists are very maybe their work is less when the patient is under GA compared to under LA, where they have to constantly check how the patient feeling, is he moving, jumping, whatever. So that kind of thing. So it's a matter of comfort. It should be comfortable to the surgeon, to the patient, as well as to the anesthetist.
So
I think
over
that's the
time, I have
critical point.
understood one thing: कि transforaminal endoscopy has limited scope, though it can be done under local anesthesia. But the main burden of patient, we call the rising population which is coming off of spine surgery, is elderly. Like knee replacement, like cataract surgery, which has evolved over time and accepted by the society. Even if my father had a cataract surgery, he didn't even inform me, because I'm going for a cataract surgery. But if you talk about the spine, the society does not accept and straight away reject spine surgery. Most of this because of the failure rates in spine. So we have to do a complete spine surgery with anything, whichever is the technique which can do a complete spine surgery, which are able to take care of everything, directly decompress facets, fuse everything. So that is why biportal is something which is able to cure the patient. This is the curing rate is better than the other endoscopic ways. And definitely the learning curve is little higher. Initially we struggled a lot, but somehow over time I was so motivated to do the surgery. So I try to troubleshoot a lot of point about the original UB surgery, unilateral. By we made it midline. We tried to remove triangulation from the surgery. We made a namaste point where we can do easily do the surgery in seconds. Where triangulation used to take 15 minutes, here we can do it in 1 second. So that is how we are troubleshooted. I believe this is a easier option for all, and whoever fellow comes, they are easily able to adapt the things easily. So
You,
and lot. So that is why things are getting better.
You're right, because the triangulation is not something which comes easily to neurosurgeons.
Yes.
Triangulation is done by knee surgeons and arthroscopic surgeons. In fact, the basic premise for starting UBs was actually directed to arthroscopic surgeons so that they pick up spine surgery. And so it is really commendable that you have picked up and you have excelled in a field in
So
a
how
in
we dog like easy go, but
correct.
work like biportal. That
Well,
is
understood,
is
understood,
the
understood, understood,
I
understood.
don't know. I don't know whether all of you know that there was an Egyptian neurosurgeon, an Egyptian orthopedic surgeon, who used the arthroscopy technique first in the lateral position in Saudi Arabia, and he went into ignominy in spite of him being the first surgeon who did discectomy in lateral position using the arthroscope and biportal technique. His name is there in history. Like Cambin, Cambin was the first guy to do transforaminal surgery. He was an Iranian, but the whole scene was, taken over by the Koreans. Anyway, what I wanted to ask these guys, both these guys, especially Dr. Dash, who has done so, and Verma, did you have any time post-operative seizures because of water intoxication?
Sir, for the whole of the procedure, we do a lot of procedure. So in the beginning phases, I had only two water-related complications. This was one in the first case where I started a UB where I took 8 hours, and the second surgery where we did my first para UB foraminal work. In those two cases, we had water-related complication. So how it happened when we started touching the patient, it was very hard. So the back was very hard. It is not soft. So we started asking the anesthetist. The anesthetist said the PIP pressure is high. We need to push the machine in the higher thing. So we thought maybe we started poking the neck and back. All are looking hard. So we thought there is a water-related complication, which is initially in the beginning phases can happen with anybody. So there was water all around. So we stopped the surgery there because the single level was done. We are planning for fusion, but we stopped fusion. So we kept the patient under ventilation for that day. We started with Lasix, so all water came out of the body, and the patient was fine on the next day. So second patient also similarly things happen, but till now, because we use water under gravity, and even with dural tears, and we do suturing and everything, never happened. The brain damage has never happened till now. So
You
touch
never
wood.
had. What about Abhijit? Did you have seizures any time, Abhijit?
No, sir, no. Fortunately, I didn't encounter any such complication. Usually, when I encounter any dural tear and all, I just happen to give a tender bug position to my patient so that the water doesn't go upside.
Reverse Trendelenburg.
Reverse tender bug, yes, sir.
So the head up so that the water remains down.
Yes, sir.
Yeah, but that was very good, and I was very happy to see that you are managing to put Surgicel also inside and wait for some time, and then remove the Surgicel once the hemostasis is done.
Yes, sir. Yes, sir. Actually, that was not my video. I have borrowed it from some other surgeon, but like it really works in few of my cases where the bleeding was very diffuse. In severely stenosed cases, when you get really engorged veins, so it's very difficult to identify from where the blood is coming. It's all around the dura and all. So just place a
Really
Surgicel or a cottonite, wait for some time, and the magic happens.
fantastic. But do you pray to God when the bleeding occurs?
So always before starting the case, I do pray to God.
We have to pray to God irrespective of the bleeding.
And one
So
more thing I've gone.
can I ask a question to both Dr. Dash and Dr. Verma, please?
Yes,
Yes,
of
Kishore.
course, you should.
We operate about 20 simple spines per week in our department.
and we are lagging behind for various reasons. And all of the we operate microscopically, none of them endoscopically. Now, I operate from 8 to 3, I operate 4 simple spines, but my complex spine colleagues, I'm not a spine surgeon, but my complex spine colleagues operate 6 or 7 spines in a day. Now, most of the patients, unless they are very elderly, they go home the same day or the next day morning. If they are elderly, which, like Dash said, most of them are nowadays, they are 80s and 90s, there is no need for fusion because they're already fused. So even for grade 1 spondylolisthesis, unless there is a dynamic instability or patients has symptoms, we do not fuse them and we only do decompression without disturbing the midline and rest of the facets, etc. Now, when our patients go pain-free, either within 2 hours of surgery or the next day, our management is asking us, what are you going to achieve extra by bringing up endoscopic spine surgery and the cost and the time that comes along with it and the learning curve? And we have not been able to convince them. So what
Uh,
should I tell them?
Before they answer, I want to ask you, what do you mean by complex spine?
Oh, sorry. Complex spine is those who undertake fusions regularly. So we have two varieties, simple spine surgeons, complex spine surgeon. I am a simple spine surgeon. I do ACDF, laminectomies, occasional plating, but I do not undertake multiple level lumbar or thoracic fusions.
And
If my patient needs that,
those are also
sorry.
discharged the next day?
No, the simple spines are all discharged next day.
No,
Yeah,
no,
or the same day.
I'm talking about the complex spines. Are they
No,
discharged?
complex spine, no, not the same day. They are discharged within a couple of days to 3 days, depending on whatever they
So,
are.
so
No,
your
I'm just
management
talking
is
about
asking you
simple.
about your cases.
My management is asking about simple spine cases, which there are majority of them, mostly elderly degen spines, and they are asking us, what would you bring extra uh, by endoscopy when your patients are already going home pain-free the same day or the next day? And we have not been able to convince them yet. So I need some guidance from these two masters.
Correct.
First thing is the psychological safety. When we discuss, we have a long pre-surgical counseling with the patient. We offer them most of the patient come from different places, different doctors. Doctor shopping is a common term as everywhere. So they will somebody go to somebody, they will ask which surgery you are going to do. You say open, they will definitely come here for surgery because everybody needs a smallest possible incision on the back. Whatever happen, whatever doing, they don't care. They want how big will be the incision, how small will be the incision, how you are going to do, how many days I'm going to stay in the hospital. These are the questions when I can resume my normal work. When this is where the endoscopy plays a normal role, because we can make them climb stairs. Every patient is going to climb stairs on the second half of the surgery. Once operate in the morning and second half they will go. If the second thing is the corporate talk, whenever initially they asked me what you are going to achieve by getting all these instruments and all, we said, suppose our simple discectomy is going to cost you 1 lakh, which is open surgery. The biportal is an advanced surgery where we are going to charge 4 lakhs. So almost 4 times the price of your revenue is going to happen because patient are choosing it. I'm not forcing anybody. I'm giving them simple option. You need this or you need this. They said we need this. This one, we are ready to pay anything for this. So both the thing, the psychological aspect of the patient has not to be, because we are not living in 2000 where there was no chat GPT, no internet, nothing. We are living in an era of internet where patients are going to watch your videos. They are going to do a lot of research before coming for a spine surgery, because spine is a myth. Still it is a myth. It is not cataract surgery anymore. It is going to be cataract surgery if you give them a simpler solution, which is bloodless, which is painless. Definitely we are cutting muscles, the patient will have pain. They are not going to pay you for the pain. They're going to pay you for a painless status post-operative.
The only way, Kishore, your question can be answered,
I don't think that.
Kishore, your question can be answered by checking how much analgesics you give versus how much analgesics Dr. Dash or Dr. Verma gave post-op.
Well, I just know we don't give analgesic because patients go home on paracetamol and we only infiltrate muscle locally by local anesthetic. So whatever is left after skin infiltration, We inject locally in the muscle, but that's about it. And patients prescribe paracetamol on a PRN basis. So what you call it, SOS basis. So they don't go on analgesics. So I don't think Dr. Dash.
Britishers are too tough, man. They're not British are not like the Marwadi patient with Dr. Dash is treating the obese, fat Marwadis. And he's taking 4 lakh rupees. He's taking 4 lakh rupees if they do biportal versus 1 lakh if they do microlumbar. Fantastic. I got a very good idea now after listening to him. I think that is a great idea. You guys are working for NHS,
And
but
one
what
level
we have
free, one
said,
level free. Sushil.
one level free also.
So, Dr. Kishore, am I
Yeah.
right? Is the perspective different? Because here, most of the patients are not government insured. They have to pay either from their private insurance or from the pocket. And in UK, they don't have much of a choice as far as what to choose, where to go. So they are sort of, even if they know about endoscopic surgery, they have to go to the center which is assigned to them and get the surgery done by the surgeon, whoever is there. Is the situation like that, or do they have choice?
You are partially correct. Most of the patients don't have choice and they are free, so they don't have to pay. Some patients do have a choice if they are insured, but they are about 3 to 5% of the total cohort. So you are right in saying they don't have a choice.
Actually,
But
that is the answer.
across no, across the UK, most of the surgeons don't practice endoscopic spine surgery. There are a couple of Indian enthusiasts who have been trained in India and now working in other places, such as Manchester, that they have now picked up doing endoscopic spine surgery. In our
Correct.
institute, we have the volume, we have the skill, we have the commitment, but the management is not encouraging us to do
You don't
endoscopic
have the
spine surgery.
So,
incentive. You don't have the
so
incentive, my
no, no,
dear.
no. So I know what I'm saying is there is no competition. If there is a guy who's sitting next door doing this, and patients start going there, and you start losing the patient and revenue and paychecks, then automatically you'll start searching for the solution. Like in my old age, I have to start some endoscopy because across the
Yes,
river
yes.
there is Dr. Patkar sitting,
I know.
charging 10 times, but still getting all the patients.
Sir, even in India, if you draw a parallel with the government institutions, there are like very few government institutions where they are adopting the endoscopic techniques and all because of the workload and all. The endoscopic is flourishing more in the private sector as compared to the government sector.
Correct,
Yeah.
correct.
So
So
what I'm
what
asking
you
Dr. Dash is, what I'm asking Dr. Dash and Dr. Verma is that is endoscopic a simple gimmick or simple spine surgery? Is it? Do you need it? Do you need it really?
No, it is not. I'll answer. It is not. The visualization is fantastic under scope. You cannot see it under microscope. The vision under endoscope is fantastic. Magnified, close look, around the corners, 30-degree scope, under the recess, everything. You just cannot compare microscopic view with endoscopic view. Microscope,
Is
you
there
feel
All right.
you are in
is there
control
an
because you are
exoscope?
always used.
Is there an exoscope
Right.
there now? Exoscopic means use the endoscope but operate exoscopic.
I don't know. Exoscope is like microscope. Like you have
So
distant
only
vision and
problem
you
with
are
the
not underwater.
microscope is the parallel vision. Suppose we are
Correct.
operating on a left-sided fragmented disc. We remove the left-sided fragmented disc. Most of the times when we understand when do microscopy, drag the muscle and try to fish out the things by not looking at things from a distance. But in the endoscopy, look from very close perspective. So even the RBCs will be visible, and any fragment. Suppose we are operating a microdiscectomy and going home, and operating a UB discectomy and going home, I'll be more preferred good sleep when I'm doing a UB discectomy because I have checked all corners from any missed fragment. That is the only thing, only advantage of a very close perspective work where you see things from a very close perspective from the axilla. You can go to the axilla, you can go to sometimes we get down migrated, up migrated disc, foraminal disc. All this can the scope can go and check for you, It's just like a drone going there on the corners and checking everything for you. Though it is not there, it's fine. If it is there, it is going to remove it for you. That is the advantage used in my practice
Yeah.
by endoscopy
No, what I meant to say,
rather
endoscopic view seen on the
because we
exoscope,
practice
and you
open,
get
we
a
practice
bigger
normal.
bigger visualization. You understand what I mean? Endoscopic view seen on the exoscopic screen, and then you have a better visualization that we
Sir,
do for the.
Sir,
Yes, sir.
the light source is away. The camera is away. The whole advantage of endoscope is that the camera is very close to the field. So think of microscope is giving you a funnel view, whereas an endoscope is giving you a reverse funnel view. So you have a much larger field which is visible. Then for the microscope, the light has to be exactly collinear to the place you're working. But whereas for the endoscope, you are not bothered about what is the source of the light because it's close to the field. Second
My
thing is,
dear, my dears, it is an exoscopic view because he is looking into the TV screen
no,
and
no,
operating.
so view is,
He's not looking to the endoscope. He's looking at the screen and operating.
sir,
Yeah.
Yeah, but
I'm talking about the
the light,
endoscope.
even in exoscope, the light source is
Is
away. The
away.
vision
Yeah,
is away.
exactly. Yeah.
So there
That's
is
not
no
right.
difference. It's just
Yeah,
that
yeah,
you are not the light is not coming in
but
between your way.
Dr. Dash or Dr. Verma are looking at the TV screen and operating. They are not operating by looking into the endoscope. Am I right?
Yes, I think that's
That
what
is
So
they
you
correct.
are
do
also not
actually.
looking.
Yes.
You are also not looking in the field. You are looking in the objective lens of the microscope.
So it's
Yeah,
a
yeah.
3D,
So
3D endoscope, right?
So,
that's
that is
what
the
I.
only difference. That is the only difference. You have a depth, actual depth perception, and endoscopes
Yeah.
have a false depth perception. But in few surgeries, like 50 surgeries, you get to know the depth looking at your screen. You just move the scope and you know what is where. So the depth perception comes automatically, and soon
But
3D scopes will be available, I think.
after all this discussion, I want to tell the youngsters the operation is about decompression the root and not about discectomy.
Yeah. But sir, one thing I would say that was not emphasized enough, but I think Dr. Das has showed nicely in his videos is that the end plate preparation that you can do and see under an endoscope is not possible under microscope.
Correct.
So
Correct.
fusion is
No
also
way.
better. Theoretically, you can get better fusion under endoscope. You will not damage the end plates. You will prepare it better, and you can visualize how much work is remaining. You will not have those problems of MI steel. If, for example, sometimes you shove in the bone and shove in the spacer, and some disc fragment which is remaining goes to the opposite side, and the patient wakes up with a contralateral foot drop or a contralateral radiculopathy. So because of the endoscope, you can go inside, I think is one of the major advantages not highlighted enough somehow.
Dr.
Yeah, I
Dash,
think
what is your opinion about extra foraminal T-lift?
Sir, we are doing extra foraminal T-lifts, but it is very easy to we remove the
Your voice is breaking.
facet.
Your voice is breaking.
Anyway, once we remove
I think there is
the
some problem
facet,
with his internet connection.
the Campbell's triangle is accessed, and we put the case through it.
What about expandable cages? Do you put
Most of the
expandable
cases
cages?
extra for
Lordotic expandable cages
only, sir.
through the extraforaminal approach.
Remove the facet.
आवाज येत नाही
We
रे.
remove the facet, sir, without
Just like T-lift.
sir. Hello.
sorry, I think you're breaking up, Dr. Dash.
Yeah. So meanwhile, I'll ask one small technical question to Dr. Verma. In monoportal, we use
Hello.
this plasma or wand mainly for extra spinal work. And once we are in the canal, we use that trigger
Sir,
flex RF.
expandable cages. Am I audible, sir?
Yeah, now you're audible. Come on.
Just go ahead. Hello.
Now, sir.
बंद हो गए. Yes, Dr. Dash. Please go ahead.
Sir, now whenever we do expandable cages, we have gone through the research, and the research says ki over time, because of the loosening of the hardware, most of the cases, expandable cages have subsidence. So
Collapsed.
we are
Yeah.
not using so that is why we are not using expandable cages anymore. We are only using dual cages. The solid fusion happens with this. Because of the endoscopy, the wall end plate preparation are very good. So the chances of having a subsidence cage backout is very, very less. We have not seen a backout till now. And we have not seen, initially we used to get subsidence, but now I had understood how to manage the subsidence. So we are curing as if exactly the cartilaginous end plate from the bony end plate very nicely. So the fusions are getting fused very fast.
I was very impressed that you could demonstrate the ALL through the endoscope.
If there is a time, I would like to
Yes,
ask
sir. That is why we are able
Dr.
to get this
Verma.
lordosis also.
Yeah. Sir, I think for the expandable cages, the problem is that as soon as you expand them, you lose the bone-on-bone contact.
Correct.
Yeah, so I think all the graft material that you have put in and then you expand the cage, you lose the bone-on-bone contact. So the whole idea of fusion goes for a toss. Just the
No, no, but the
just
secret is
like
not to put no. The secret is not to put the bone, to rely on the bone in the cage. You are supposed to pack the bone
outside.
before you put the
Yeah,
cage.
yeah. Agree. So even then, sir, when you expand it, you basically expand it to get that
Ready?
lordosis.
Huh?
And
And
then the graft which acts like a structural graft, then which is under compression, is then not under compression, and that's
I
not an
agree
ideal
with you.
state for fusion.
The same thing in expandable cages in the cervical spine. I never
Correct, correct,
believed
correct,
in.
correct,
I
correct,
never
sir.
believed in them
Yeah,
because the bone graft starts floating.
correct, correct, sir. Correct.
Abhijit, what is the question for Abhijit? What is the question for Abhijit?
Yeah, so Abhijit, in monoportal, we use this one plasma mainly for extraspinal work. And once we are inside the canal, we use that fine trigger flex, which is a 2.5 millimeter probe, and it is supposed to be much milder. So usually they don't advise to use plasma inside the canal. Uh, have you had any time root injury or dural injury because of burns because of plasma? Or
Yes,
how
sir.
do you avoid that? Or
No,
how
no,
do you
sir.
avoid that?
I have burned my hands with all these injuries. I was using that point probe near the root, and like patient, like she still comes to me with lots of paresthesias and all and all. So like I have been like more cautious using it near the root or ganglionic area or dura. In the center part of the dura, I am quite confident to use it, but near the root, I am like a bit wary of using that wand there.
Do you have a small trigger flex probe, that flexity probe for UV like we have in
Yes, sir.
monoportal?
One of the probe which I have shown there, its diameter is hardly 1.4 mm diameter is there.
Okay, okay,
So
okay.
with
So you
which
use a small probe for those
yes, yes,
places.
absolutely, absolutely, sir. Only the pinpoint the bleeding and then apply it there only. And it should be like
Okay,
in pulsatile manner, not a continuous RF use.
continuous manner.
Yes.
Okay, yeah,
That used to
got
come.
it.
That used to come from Arbe, right? Arbe used to give those flexi probes, and they used to cost 30,000 rupees for three
Originally it
cases or
was
four cases.
Eloquence. Eloquence, I think, originally was developed by Eloquence trigger flex.
Hmm. Anyway, the definitely the way forward for most neurosurgeons who are attending this meeting or who will see this webinar, Dr. Dash and Dr. Abhijit Verma have done remarkable work, and their footsteps have to be followed if one has to move on into spinal surgery. I don't think there's any competition between us and the orthopedic surgeons. We should not look at it as if they are grabbing. It is we have to deliver what the patients want. And Dr. Dash has repeatedly said in his meeting that when you tell patients that this is a laparoscopic surgery, they are going to be very thrilled and they're going to accept this operation rather than open surgery. I feel that youngsters who are on this webinar, or those who see this webinar later, should make it a point to train themselves in this kind of surgery, and they will progress. For people like me and Datta, we are now, dinosaurs who are going to go into the ice age, and then there will be a meteor which will be stuck on the earth, and we will disappear.
Yes, very much. but I wish I would have been in that era to learn good endoscopic surgery.
But when I began, there was no microscope. When microscope came, I was so thrilled,
Datta, it's never
Uh,
late. Datta, it's
yes,
never
yes.
late. I
Yeah,
started 2.5 years ago. We are almost same age.
I have to manage so many other things now.
Yeah,
Have
I
you
can
not gone to the
understand.
ACNS? Have you not been in the ACNS meeting, Datta? What are you doing there in
Yeah,
the
yeah. I've come through the ACNS workshop only now. Tomorrow I will attend the orations and all. You are
Okay.
there or not? You are not
No,
there?
I'm not there. I'm not there. I'm not there.
Why?
There were too many patients, and I thought that
Ah,
I will do patients rather than go there.
Arre Bapre. That's a loss to ACNS.
That's all right. But then, Papi Pet ka sawal. Is
Your body.
Atmaranjan presenting his case in his work in ACNS? And Abhijit, are you presenting your work in the ACNS?
So we have not been called for that.
Oh
Arre?
my God, it's a shame, yeah. It's a shame. And Atmaranjan, you have not been called?
No, sir.
Oh my God, and Abhijit?
No, sir, no.
So the
Arre?
problem is that neurosurgeons still feel that cranial surgery is more important, and
Which
actually
is limited in
neurosurgery is
number.
dwindling, which is now limited in number, and bulk of neurosurgery is spine surgery. They will wake up after some time.
Already getting late.
When
That's what
everything
I'm
will be
trying to
taken by
stress.
orthopedic surgery.
No, they will not.
That's why I'm.
As long as you guys are there, no orthopedic surgeon is going to take it.
I will pass on the message tomorrow. Don't worry.
Yeah, you
Yeah,
pass on the
yeah,
message
Datta,
that you did
you
not
have
call
to. We discussed it
Atmaranjan
last
Das
time
and you
in
didn't call
MCNS.
Abhijit Verma.
Yeah.
Sir, I've been called, but for brachial plexus.
Oh my God.
Chandan,
So
Chandan is a part.
that is called strategic maneuvering by Goel
No.
and
Yes,
Abhijit.
yes, yes. Chandan is a part of ACNS.
So they have done strategic maneuvering to keep him away from spinal surgery because Chandan doesn't believe in facet fixation.
Sir,
Yeah.
I'll mute
Anyway,
myself.
yeah. Anyway, concluding, I would like Dr.
Thank
Das
you.
to say a few words to our youngsters about the point that Chandan mentioned, that out of every two surgeons who take up, 50% give it up. So how to prevent that? Dr. Das would guide our young neurosurgeons about that, please.
I believe all of us should take as a neurosurgeon because we know the number of brain surgeries and taken up by some of the endoscopic taken by ENT people now. Many people are going for radiation, gamma knife, and all. Number of brain surgery are actually less. We all struggled in the initial part when we started. Only 15 cases will get maximum stroke, decompression, haddi nikalo, haddi wapas rakho. The game is only that 90.
Dr. Dash has gone to the theater here at this time in the night. He's wearing a cap.
He is a workaholic. He is in hospital 24/7.
Yes, so
Arre
He's wearing
Bapre.
a cap now.
so the last case. So
Arre,
fellows have started. So that is what we believe ki, because when we started doing brain, I used to do 15 brain, but after was started with biportal, CDR, kyphoplasty, the numbers have gone up more than 100. Surprisingly, there are so many cases suffering from spine and awareness is going up. Most of the people are in the major places, orthopedicians have started doing a lot of spine because of this. There's growing craze of spine surgery in lot of doctors, including orthopedician, pain physician, anesthetist, neurosurgeons, disciplinary. If we are losing this branch, then we'll die poor. That's what I believe. Uh,
Yeah, you should.
so
And also the
so
probability of a brain tumor patient's relative getting a brain tumor is far less compared to a spinal problem.
and the
Spinal
brain
problem.
Correct.
tumor thing, there are two scenarios. If the patient is a elective brain tumor, either they will go to institute because they are poor, or they will go to Delhi, Mumbai, or bigger center where they have money. But for spine, definitely the numbers are so. Every alternate patient is having spine patient. We are going to the literature. 15% of the population is going to have lumbar canal stenosis, and the awareness, if it grows, most of the patients are not aware about the symptoms. They say, "Ki I'm walking fine. I'm able to stand fine. Why I need at all of spine surgery?" There we say, if you want to walk properly, you need a spine surgery. This awareness is going to grow up. Like in 20 years back, if you talk about cataract surgery, every elderly lady was not planning for a cataract surgery because they will go blind. But now things have changed. So that is what is going to do for spine. It will be socially acceptable. I believe this is a good thing for neurosurgeons to venture.
Great.
Patka sir
High
has
time,
told me
high time to
Patka-
venture, not good thing. High time to venture. You should go to
Yes.
ASICON to understand the pace and the passion and with
Very, very
what
high.
they are moving, and they have almost uh, shut the door on our face. Our
Don't
neurosurgeons
worry
are
about
almost
that.
Yes,
not
Don't worry.
welcome.
absolutely, absolutely.
Don't talk about it. Nobody can shut the door on our face here. We are neurosurgeons.
No, we are shutting the door on our face.
That's all
That's
right.
right.
the Patka sir has told me a golden ratio long back when I was working with him. He told like there is 70% of spine in private practice and 30% of brain surgery. And after 5 years of separating from him, I do believe that 70% is still spine in the market, and
Yes.
50% barely you get as brain surgeries.
See, I tell you that, we are like leopards. We have become like leopards. There is one leopard who requires 300 square kilometers to feed himself. Otherwise, he starts encroaching on human areas. He starts killing cows and dogs and sometimes small children. So we have to train ourselves in something new to fill our stomachs. And the something new is spine surgery. Otherwise, we'll have to encroach on, abnormal areas like leopards, and then people will catch us and they will kill us. When I came to Pune, there were only 4 neurosurgeons, and I was the fifth. And today there are 150 neurosurgeons. Just imagine, the incidence of brain tumor is 1 in 5 lakhs, and the incidence of spinal surgery is in human beings is about 3 to 4 in 100.
So
So we
Dash is
must
saying
focus.
50%.
We must
Yes.
focus on spine surgery. No, I don't think we should overdo it also. But at the same time, we must learn this aspect of endoscopic spine surgery, like Dash was saying, that if we can do something which is minor and like what Varma has taken up, Varma has really clicked and he's in Jaipur and he's become the popular endoscopic spine surgeon in Jaipur. So I think that is the way to go. And in future, I think that is what is important. The whole thing is about result based. When you treat a stroke and you put a stent and you do what is it called, emergencies, you form stroke hubs and bring patients and do thrombolysis. The figures are very big, the amount involved. But if you do good spinal surgery, patient is going to become all right and you are going to become popular in society. So I think what these guys, I remember Dr. Dash in one meeting said that I never did any training. I just saw and decided the anatomy and I started deciding on my own after looking at videos. Is that correct, Dr. Dash?
Yes, sir, absolutely. Because we knew open anatomy, we need the
Correct.
anatomy. Well, it is just a technique.
He didn't have a mentor. He's a Swayambhu. He's a
Just a
Jyotirling. He
technique.
learned on his own. He didn't require any guru. He's a
So that is also
Jyotirling.
one lesson to learn.
Yes, Dr. Dash is a Jyotirling, Swayambhu.
It doesn't work with
Yes, sir.
everybody. It doesn't work with everybody.
He is working like Shiva. He is operating now
The
also.
first like us need to be
There are only 12
guided and
there are only 12 Jyotirlings in this world, and Dr. Dash is one of them.
Too much, sir. Too much.
No, but I think for me it is an eye opener what Dash is doing, because he
Hmm.
puts the videos on the group, but to have see him in a lecture, I think it is quite.
And what about Abhijit? Abhijit is another Lord Ganesh, man. Abhijit Verma is a Lord Ganesh. I call him Peter Scott. Anyway, I'll tell you some other time. Okay, bye bye. Good night.
COVID memories.
COVID memories.
Good night,
So
sir. It
thank
was
you,
wonderful
thank you,
interacting
thank you.
with you.
Thank you
you
for
all.
this fantastic session.
Thank you,
Thanks,
thank
Das and
you,
Verma
Thank,
and
thank you, sir.
podcast sir,
thank
Chaudhary
you,
sir.
thank
Bye
you.
bye.
Bye. See you soon.
Bye.
Yeah,
Good night,
this
sir.
will be one of the
Good night.
highly viewed YouTube afterwards.
Yeah.
Bye bye.
Bye.